incision lenticle extraction or SMILE is generally considered a safe procedure with a low incidence of intraoperative complication. After docking the cornea, the femtosecond laser then proceeds to create a lenticule cut, a side cut, then a cap cut, and finally the incision to remove the lenticule. Using the point dissector, anterior and the posterior plane is identified. Following this, a blunt dissector is used to first separate the anterior plane, followed by the posterior plane. With sweeping motion, the lenticule is completely separated and then extracted using specially designed forceps. But sometimes things don't go as planned. Of all the SMILE complications, let's discuss a few. Suction loss can occur in case of eye movements, wet corneal surface, improper cone selection, and wrong head position. Scenario: we will demonstrate a suction loss during the posterior lenticle cut, which can be simply managed by converting it into a flap-based procedure. Suction loss at cap cut usually happens once the fixation light is blurred for the patient and the patient tries to search for it and leads to eye movement. This can be simply managed by redocking and making sure that the cone is centered. So how to manage the suction loss? If the posterior lenticle cut is less than 10%, then you can restart the procedure. But if it is more than 10%, then convert to LASIK. And if it is at the anterior lenticle cut, then repeat docking. Black spots occurs because of debris present between the patient's interface and corneal surface, dry cornea, or excessive use of topical anesthetic drugs, and can lead to difficult tissue separation, damage to the stromal bed, and delayed recovery. In this video, we see several dark spots which leads to lots of resistance during dissection done by blunt tip dissector due to uncut areas. But it is not very confluent and large and does not cause much difficulty and can be managed in a usual way. In case of very large and confluent area of black spots, it is better not to attempt any dissection or convert into LASIK. So how to manage a dark spot? If it is small, then continue in usual manner, but in case of large and confluent black spots, abort or convert to LASIK. Retained lenticule can present as a nightmare for even a most experienced surgeon. So what are the risk factors for retained lenticule? Factors for retained lenticule is irregular astigmatism, a thin lenticule, incorrect identification of lenticular planes, opaque bubble layer or black spots, improper technique of dissection. Intraoperatively, black spots was observed during laser firing. On dissection with the blunt tip dissector, we faced persistent resistance at 5 o'clock position with sudden loss of resistance at other sites, which brought the surgeon to suspect of retained pit. So the lenticule was examined to ensure any loss of its part. It is imperative to examine all the lenticles after removing them from corneal stroma to ensure that there is no bit which is retained. Here we noticed missing lenticule, so pocket exploration was carried out, but the retained bit was not located, which was then located on slit lamp examination easily, so we used the forceps and pulled out the retained bit. So to prevent the retained lenticule, we must completely separate the lenticule from both the surfaces and the side cut, ensure optimal corneal surface moisture, clean contact glass, and a thorough slit lamp examination at the end of the surgery. So if you can't find the lenticule in 10 minutes, postpone the surgery by 4 to 12 weeks, reassess with topo, ASOCT and clinical photo, and do the exploration by an experienced surgeon or topo guided PR. Last but not the least, a buttonhole cap due to wrong plane of dissection, which can be caused by sudden eye movement or improper dissection technique, and thin lenticule. The dissection has to be carried out carefully and is managed by using the forceps to localize the anterior plane. Due to continuous manipulation, we can also see a tear at the SMILE incision site. Management of cap tears depend upon the size. The small tears outside pupillary area can be left as it is, while for the large tears we can apply bandage contact lens. Tears can heal with a faint scar. There is also a risk of epithelial ingrowth, and for the beginners they should use a 4 mm incision size. So to summarize, SMILE is a new technique with little learning curve. However, complications may occur like any other. So careful planning is important. Dark spots are sites of incomplete femtodissection. Examine the lenticule and ensure that no fragment is left behind. Results of SMILE varies from surgery to surgery and depends upon various factors. For all surgeons, complications happen. It's just how you deal with them. Each challenging case is a lesson, which, if managed properly, will keep a surgeon smiling after smile. Thank you.
Very nice collection of all these complications. Initially, it does happen if you have too much of fluid on the surface, then risk of suction loss is there. If there is dry surface, then you get these dark spots and all that. Nice, and in the end, a nice photograph.
Thank you, sir.